Bismillah ar-Rahman ar-Rahim. You can start recording.
نعم أستاذ بلش.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Today we are talking about a very important aspect for the anesthesiologist. It is the pharmacology. And the pharmacology consists of several important sections, but the vital section to understand all the pharmacology is the understanding of general pharmacology. The general pharmacology will focus on the basic principles of the drugs, and after a while, when you are reading something like propofol, biopenton, there will be a mentioning of several terms without explaining of these terms, and these terms should be well understood in this section, general pharmacology. For example, when we said the availability of propofol is like something, but what is the availability? We have to know the availability in the section of general pharmacology, not during the reading of propofol, biopenton, muscle relaxant, or any another medication. So this is the importance of general pharmacology, and myself focus very strongly on the understanding of general pharmacology. And at the same time, I like it. I like it, the general pharmacology, because it represents the basic principle of understanding of the pharmacology topics. So today we are starting by first part of general pharmacology, and next week we will talk about the second part of this important section. I study pharma and
أستاذ إذا ما تصير زحمة آسف على المقاطعة، لو تسوي ميوت للكل يعني الصوت ما يطلع واضح عندنا، يعني إذا ما تصير زحمة. أكو بعض الزملاء فاتحين مايكات فالصوت عندنا يعني مو واضح.
Okay, I muted all.
Thank you.
Why an anesthetist study pharma? An anesthetist study pharma because the pharma is the chemical medications used during anesthesia and intensive care and pain medicine. So pharmacology regarded as a vital aspect for the anesthetist during his or her daily work. And there are several questions should be answered at the end throughout this presentation. What's the bioavailability? What's the bioavailability of IV administered drugs? What's the bioavailability of peroral administered glyceride trinitrate? What's the volume of distribution? Does the volume of distribution govern the bolus or maintenance dose of drugs? How the administration of muscle relaxants like rocuronium, fentanyl, affected by volume of distribution in obese and infant in comparison with normal weight adult person? What's the first pass metabolism? What's the zero order kinetic? And what's the first order kinetics? All these questions will be answered at the end of this presentation. And if any of these questions will not be answered, please allow me to answer it. Are you hearing me good?
نعم أستاذ، صوتك جدا واضح.
نعم صوت كلش واضح.
Clear.
So now, what is the pharmacology? Pharmacology, originally from Greek word, consists of two words, pharmakon and logos. Pharmakon is the drug and logos means science. So it is the science of drugs. So it is the study of drugs and their actions on the body. So it is the science of drugs that dealing with the study of desirable and undesirable effects of all drugs. And the pharmacology can be subdivided into several science and aspects. The pharmacokinetics means what the body does to the drug, and the pharmacodynamics means what the drug does to the body, and the pharmacotherapeutics, which is the study of the use of the drugs, and the pharmacy, where the preparing suitable dosage form appear. And also there is a study of toxicology, which is regarded as the toxic effect of all medication. The drugs in general is any substance or product that is used or intended to be used to modify physiological system or pathological states for the benefit of the recipient. So any drug has one of two important purposes, either modifying the physiological system or interfere with the pathological process to decrease the harm effect on the patients. And each drug has several names. First name, chemical name, in which state its chemical composition and molecular structure. And there is generic name, which is usually suggested by the manufacturer. Official name as listed in Pharmacopoeia, which is the يسموها دساتير الأدوية. Brand is the trade or proprietary name يسموه. فإذا ناخذ example to explain that, for example, إذا ناخذ this drug chemical name para-acetyl amino-phenol, generic name يسموه paracetamol, the brand name يسموه باراسيتول. فهذا الدواء أول ما طلعته شركة البراند، الشركة الأم سمته باراسيتول. بعدين كل شركة تطلع تسمي حسب ما هي ترتقي، فممكن تسميه باراسيتامول، ممكن تسميه أي اسم آخر له علاقة باسم الشركة. ناخذ دواء ثاني اللي هو الكيميكال نيم 1,4 بنزودازيبين انالوج، generic name البرازولام، official name البرازولام USP، البراند name البراكس. From this example you can know that any drug has several names, chemical name, generic name, official name, brand name. ممكن نقرب لكم مثل آخر، ناخذ الدايكلوفيناك، chemical name مالته هو دايكلوفيناك. إذا نروح للبراند نيم، براند نيم هو الفولترين. ممكن generic name موجود هسه بالأسواق يسموه Orphan، وهذا أيضا له official name بالدساتير الأدوية. The nature and sources of drugs come from several sources, maybe from mineral like liquid paraffin, magnesium sulfate, or from animal source like insulin or thyroid hormone, or from plant origin like morphine اللي هو عبارة عن ثمرة or quinine, or maybe synthetic like the aspirin or sulfonamide, or maybe originated from microorganisms such as penicillin or other antibiotics, or the drugs produced by genetic engineering, like nowadays most of the human insulin and other hormones come from the genetic engineering rather than from animal origin. Poisons in small doses are taste medicines, and useful medicines in too large doses are poisonous. And this is very a great statement that the poison, you can get a benefit from it by using in small doses, like that originated from bacteria or other poisons, and any drug which is useful but in large doses converted to poisonous, even the paracetamol, which is the most relatively safe drug. What is the difference between dose and dosage? Dose is the quantity of a drug administered at one time. For example, 500 milligram of paracetamol. While the dosage is the amount of a drug that should be given over a time. For example, 500 milligram paracetamol TID for 3 days. TID means 3 times per day, and this should be continued, for example, for 3 days, 5 days, according to described dosage. What is the pharmacokinetics? Pharmacokinetics, the study of what the body does to the drug. It is the study of absorption, distribution, metabolism, and excretion of drugs. So it is the fate of a drug from the start of entrance to our bodies till the exit from our bodies, and generally classified into 4 important phases or steps: absorption, distribution, metabolism, and excretion. Absorption means how the drug is moved into bloodstream from the site of administration, while distribution, how much drug is moved to various body tissues, organs, depend on blood flow through these tissues. Metabolism, how the drug is altered, means broken down, and the excretion, how much of the drug is removed from the body. There are several forms of the drugs. Some of these as a tablet, capsules, injection, infusion, solutions, cream, suspension, aerosols, several forms of drugs, and according to the type of drug, the pharmacological prescribed the most suitable form according to criteria and properties of these drugs. Absorption is the movement of a drug from its site of administration into the blood. The rate of absorption determines how soon effect will begin. If the absorption is fast, means the onset of action is rapid onset. While if the rate of absorption is slow, there will be a slow onset of action, of effect. The amount of absorption helps to determine how intense effect will be, the drug. If there is good amount to be absorbed, there will be good effect. If the percent of absorption amount is a small percent, we have to increase the dose because we already know that this drug will be of low amount of absorption. So we have to increase the dose to get the good effect. Factors affecting drug absorption: rate of dissolution, that is to say, the original drug dissolute into its important constituents, and the surface area of absorption. As the surface area increase, the rate of absorption increase. The blood flow from this area, with increasing blood flow, the absorption increase and will be rapid. Lipid solubility and the pH partitioning. The pH depends on the type of the drug. Some of the drugs favor basic pH and other group favor the acidic pH. And we will talk about this. And regarding the absorption, if we look at this, suppose this is the site of administration here the drug, and this is the target to be reached, vascular system. So there is always what is called biological barrier. This is the biological barrier. And the biological barrier is different in number according to the route of administration. For example, if we administer the drug by IV method or route, there will be no biological barrier at all. But if we administer the drug by, for example, intramuscular route, there is single biological barrier, which is the endothelium of the vessels, endothelial cells. After the entrance through these cells, there will be reaching of the drug to the vascular system. While if the drug administered by, for example, oral, there will be two biological barriers. One of them is the GIT wall itself. We will talk about that. And another is the entrance to the vessels through the endothelium wall. So the number of biological barrier is different according to route of administration of the drug. Here, in general, the administration methods can be classified into enteral, and under this headline, there is oral, sublingual, and rectal. And parenteral, injectable. And under this top line, there is intravenous, intramuscular, and subcutaneous. And topical, and under this headline, there is intranasal, inhalational, and intravaginal. The advantages and disadvantages of different routes of administration. Regarding the safety, if we talk about safety, the higher safety by using oral and the least by using IV route. In between, the IM and subcutaneous. And regarding the convenience, the higher convenience by oral also, and the least by IV administration, and in between subcut and IM. And regarding the patient compliance, the higher compliance of patients also by oral and the least by IV. While if we talk about the bioavailability, that will be explained in next slides, the high and reliable bioavailability by using IV route of administration, and the least by using the oral route. And regarding the onset of action, the immediate onset of action by using IV, and the delayed onset of action by using oral. And if we talk about the cost will be higher with IV routes, and the low cost will be by using oral medication. And you have to consider that all these factors play a role in the decision of which type of or route of administration to be chosen for certain medications. If we talk in details about, for example, peroral route, there are several forms for peroral forms of administration. There are liquids, elixir, syrup, which is fastest, and suspension, powders, capsules, tablet, coated tablets, enteric coated tablets. And from starting from liquid has the fastest, while the enteric coated tablet has the slowest effect. In general, the graph of blood level against time look like this. This is the blood level in concentration, and this is the time with the time. So here, starting by higher level in IV route, and with the time, there is decreasing and deceleration of the curve, means that the concentration will be decreased with the time. While for oral route, the graph of blood level will be like this. Increase slowly, reaching the peak, and then decrease slowly. What's happening in these two phases? This is phase 1 and this is phase 2. Here, the absorption and distribution start looking at the effect of the drug, and here the metabolism and excretion start, so decreasing the level. So the peak effect will be in this time, from here to here. And here there is no good concentration to start effect, and here the concentration decreases, that cannot produce an effect. If we talk about IV route, the advantages of IV route is the rapid onset, controlled. Controlled means if we want to administer, for example, 50 milligrams, all these 50 milligrams will be administered reaching the IV and can produce the effect. Controlled, while the oral uncontrolled, because the absorption is widely different and varied. Use of large fluid volumes, use of irritant drugs. You can use the irritant drugs through the IV to avoid the irritability of these drugs. The disadvantages of IV route: high cost, difficulty, تحتاج IV skill, inconvenience، مريض مو كلش يعني يتقبلها. Irreversibility: IV administration can be dangerous because once a drug has been injected, there is no turning back. While, for example, in peroral method, we can induce vomiting to get rid from high percent of the effect of the drug. Also, the fluid overload. When drugs are administered in a large volume, fluid overload can occur. This can be a significant problem for patients with hypertension, for patients with kidney disease, or with heart disease. I have to focus on this disadvantage because in our daily work, most of anesthetists put a drug in one bottle of normal saline or glucose water, while actually no need always to put the medication in 500 bottle of normal saline. We can use the drug in a bottle of just 100 ml or 50 ml. Why? To decrease the fluid if the patient actually does not need such volume of fluid. So it is not necessary always to put the medication in a 500 ml of normal saline or glucose water. And other disadvantages, possible disadvantages, is the infection can occur from injecting a contaminated drug, and also the embolism. It must be noted that a solution prepared for use by different routes will differ in concentration. For example, the solution for subcutaneous administration are more concentrated than that prepared for IV or IM route of administration. So the solution for intravenous use are almost always diluted. So if a solution prepared for subcutaneous use were inadvertently administered IV, the result could be fatal. Why? Because the concentration is higher, and some of these medication may has important dangerous side effects that affect mainly the heart sometimes, the systemic resistance, or the lung, or the central nervous system. Regarding the intramuscular, if you remember, we talked about the number of barriers. So the barrier for the absorption in intramuscular route is single barrier, which is the capillary wall. And the absorption pattern, the drugs administered IM may be absorbed rapidly or slowly. Why? Because the rate of absorption is determined largely by two important factors. First, the water solubility of the drug, and second, the blood flow to the site of injection. As the blood flow increase, the rate of absorption is increased. The advantages of IM route can be used for parenteral administration of poorly soluble drugs. If the drug is poorly soluble and we administer it through IV, there will be a precipitation of this drug inside the vessels and may lead to two important side effects. First one, occlusion of the vessel, and second one, regarded as a thrombus, can be transmitted to important vessels like that of the brain or the heart. A second advantage of the IM route is that we can administer depot preparations, which is the preparations from which drug is absorbed slowly over an extended time. For example, the dipomidrol. The dipomidrol is a type of steroid, you know, and this steroid can be administered by IM, and the effect of this drug can be prolonged for months. Why? Because there is slow absorption of this depot, while this is impossible to be administered through IV route. And if we return back to first point regarding the IM route can be used for parenteral administration of poorly soluble drugs. One of the IV anesthetic drug is poorly soluble drug. IV anesthetic drug is a poorly soluble drug. علي ناظم تسمعني؟ علي ناظم عمار اياد تسمعني؟ عمار اياد دعاء عبد الله تسمعيني؟
نعم أستاذ.
اوكي دعاء شو صار لك بالتخدير؟
نعم أستاذ.
شو صار لك بالتخدير؟
أستاذ يعني 8 أشهر
فقط بس هاي
إيه. إيه نعم أستاذ، إحنا بوست روتيشن.
هم صادفك التايوبنتون البنتوتال اشتغلتي بيه؟
إيه نعم أستاذ.
اشتغلتي بيه؟
إيه نعم.
شوفي التايوبنتون هو واحد من الدراج اللي نقدر نقول عنها poorly soluble drugs، ولذلك احنا نشتغل بيها نحتاج انه نسوي لها dilution with good amount of fluid حتى to decrease the precipitate of the thiobentone.
نعم.
الثايوبنتون إذا ما سوينا له good dilution with good amount of fluid راح يصير عندنا occlusion of the veins or can this precipitate transmitted from venous side to the heart and from the heart as a thrombus to arterial system. So this is the advantages of using IM by using a drug that poorly soluble drugs. Actually, we cannot use thiopentone by IM route because we'll lose the benefit of the thiopentone as ultra short acting drugs, while this benefit can be taken for other drugs not needed for ultra short acting effect used in by IM route.
نعم أستاذ.
Regarding the disadvantages of IM is the discomfort and inconvenience. معظم الناس تخاف من IM tricking. Some preparations can be painful, means the drug itself painful after the injection in the muscle. IM injection can cause sometimes local tissue injury or nerve damage if injection is done improperly. The pharmacokinetics of subcutaneous administration are nearly identical to those of IM administration. And as with IM administration, there are no significant barriers, only single barrier to the absorption, which is the endothelial cells. Subcutaneous and IM administration have nearly similar advantages and drawbacks. The abbreviation of PO, which is peroral, is used in reference to oral administration. Barriers to the absorption, if we talk about the oral, there are two important barriers. One of them is the layer of epithelial cell that line the GIT tract, as the oral preparation can be absorbed from stomach or intestine. And the second barrier is the capillary wall. So the drug to reach the intravascular compartment has to pass through these two important barriers. The epithelial cell that lines the GIT tract and the capillary wall. Because the walls of capillaries that serve the GIT tract offer no significant resistance to absorption, then the major barrier to absorption is the GIT epithelium. To cross this layer of tightly packed cells, the drugs must pass through cells rather than between them. So the drug has to pass through the endothelium cell rather than to pass between these two cells. Factors that influence oral absorption, solubility and stability of the drugs, gastric and intestinal pH, gastric emptying time, food in the gut, co-administration of other drugs, special coating on the drug preparation. Amir Hamid,
بين استاذ اسمه.
what does it mean special coatings on the drug preparation?
دكتور هو يعني المفروض اكو سبيشال كودينج مثلا يعبر الستومك ويوصل للانتستين، فيعني ممكن البي اتش او الاسيديتي مال الستومك تاثر عليه، فيعني هذا اللي يقال.
Special coating not always present in all drugs, but for example, if we talk about aspirin, there is aspirin, coated aspirin and non-coated aspirin. The coated aspirins to decrease the irritant effect of some drugs on the stomach or intestine. Advantages of oral administration: it is easy, convenient, and inexpensive. Because of its relative ease, oral administration is the preferred route for self-administration. Disadvantages in variability: the absorption can be highly variable, so it is difficult to control the concentration of a drug at its site of action. Sometimes you expect some concentration of absorption, while if the drug given in association with some types of foods that prevent the absorption of this drug, we will lose the effect of such a drug. Inactivation: sometimes some type of foods or drugs can inactivate others. For example, use of dairy products with tetracycline, patient requirements, and local irritation. Now we will talk about the bioavailability, which is the fraction of administered dose of a drug that reaches the systemic circulation in unchanged form. As you know, not all the dose administered will reach the systemic circulation. So the fraction that reach the systemic circulation, we call it the bioavailability. So the bioavailability of IV administered drugs will be 100% because we administer the drugs directly to the final target, which is the intravascular compartment. And we have several phases that affect the drug before reaching the systemic circulation. If we look at this, this is the original dose, and here there's losing of some of this dose by destruction in the gut, and some part not absorbed, and other destroyed by gut wall. We already mentioned that gut wall is the first barrier for the drug given per oral, and after passing the gut wall and reaching the portal circulation, some of the drug also destroyed by liver before reaching the systemic circulation. So the bioavailability here, the dose here, not like the dose given here. Factors influencing the bioavailability: the dosage form, chemical form, dissolution and absorption of a drug, route of administration, presence of food or drug in the GIT tract, first pass effect. We will talk about first pass effect data, the extent of drug metabolism before reaching the systemic circulation. Here, there are several concepts of critical thresholds. We have what is called minimum effective concentration, which is the minimum level of a drug concentration needed for desired therapeutic effect to be present. And there is maximum safe concentration, the maximum level of a drug concentration above which the toxic effect occurs. The minimum toxic concentration, the minimum level of a drug concentration that produces toxic effect. And also we have the maximum effect, which is the greatest response that can be produced by a drug, above which no further response can be created. Sometimes we call it peak effect. The onset means how long before a drug is able to exert a therapeutic effect, and the duration, how long a drug effect lasts. If we look at this curve, this is the minimum effective concentration, and this is the maximum safety concentration. Above the maximum safety concentration, there will be a toxic effect, and below the minimum effective concentration, there will be no effect. So the onset of action started with the minimum effective concentration, and the duration of the drug ended by reaching again the minimum effective concentration. So the onset of the drug by first minimum effective concentration, and the duration between two minimum effective concentration. First one during the acceleration of care, and second one during deceleration of the care. We have concentration maxima, Cmax, and Tmax. Cmax, maximum concentration achieved in the blood, and Tmax is a time taken to attain the maximum concentration. If we look at this graph, this is the maximum concentration, and this is the time to reach or attain the maximum concentration. Also, there is important area, we call it area under the curve. Area under the curve. This is the curve. We represent the concentration of any drug, and here the time. And from this area, we can conclude several important criteria regarding the effect and action of the drug. Here the minimum effective concentration. Here the minimum toxic concentration that is not reached to avoid the toxic effect. And between the minimum effective concentration and minimum toxic concentration is the allowed therapeutic range of the dose and concentration. And this is the Cmax, the peak concentration, and this is the Tmax, and this is the onset, and this is the duration. All these properties can be taken by understanding this curve and from what is called the area under the curve. So area under the curve is the area under the plot of a plasma concentration of the drug against time after the drug administration. Now we will talk about distribution, which is a branch of pharmacokinetic. إيثار أياد.
نعم أستاذ.
إيثار احنا قلنا pharmacokinetic إلى 4 sections. What are these?
Absorption, distribution, or metabolism and excretion or elimination.
Very good. Now we are talking about the distribution.
Distribution.
Good. Distribution is a branch of pharmacokinetic which describes the movement of drugs throughout the body. And suppose that this is the free drug, this is the free drug, and the absorption from this side, and the excretion will be from here, and in between is the distribution, and through this distribution, the drug reaching the tissue reservoir, and in the tissue reservoir, it is either free or bound, and at the site of action receptors here, which is either free or bound, and this is the systemic circulation, and in the systemic circulation, the drug either free or bound the drug, and the biotransformation, which is the metabolism, also occur in this area, the area of distribution, before reaching the excretion phase. Drug distribution is determined by 3 major factors. First, blood flow to tissue. If there is good blood flow to tissue, there will be good distribution. The ability of a drug to exit the vascular system, the ability of a drug to enter the cells. These are the 3 important major factors that affect the distribution. Blood flow to the tissue. In the first phase of distribution, drugs are carried by the blood to the tissues and organs of the body. The next step is to exit the vasculature to the tissue. Exiting the vascular system, the ability to leave the vascular system is an important determinant of drug actions, since most drugs do not produce their effect within the blood. Means producing their effect within the cells. Necessary means the ability to leave vascular system is necessary for a drug to undergo metabolism and excretion. Entering cells, the factors that determine the ability of a drug to cross cell membranes are the same factors that determine the passage of a drug across all other membranes, which are lipid solubility. The increase in lipid solubility will enhance or increase the ability to pass through the membrane. The presence of a transport system, or both of them. All of you have heard about plasma protein binding, and many drugs bound to circulating plasma proteins such as albumin, lipoproteins, glycoprotein, and globulins, and others. So we have a free form of a drug and bound form. The free form actually is the active form pharmacologically, while the bound form cannot produce any effect, so it is inactive form pharmacologically. And here if suppose that this is the receptor and this is the drug, here the drug can produce effect, while here not, because the drug here bound to the protein cannot produce any effect through the receptor. What are the effects of protein bindings? Acts as a temporary store of the drug. As the free drug decrease in concentration inside the vascular compartment, there will be new liberation of free drugs from the already bounded drugs. So it is act as a store. And at the same time, it is a cause of prolongation, the effect of the drug, and it causes prolonged low level of the drug. Slowly released from the bound reservoir, delayed metabolism, delays excretion, decreases its entry into central nervous system. All these due to protein bindings. The percent of bounded part depend on several factors like renal failure. In renal failure, there is decrease in the percent of bounded drug. In inflammation, there is an increase in the percent. Fasting or malnutrition, there is decrease. Competition from other drugs can also affect the percent of bounded drugs. أريج خالد سمعيني؟ أريج خالد فاطمة عبد المجيد.
نعم أستاذ.
Fatma Abdul Majid, competition from other drugs can also affect percent of bounded part. How?
أستاذ لأن راح يصير binding of other drug decrease the effectivity, the action of a drug. Some drugs, when it's display other drug, free drug more effect and active state, while the bonded drug decrease the effect because it's inactive phase.
Okay, good. An example about this last statement, competition from other drugs can also affect percent. Warfarin, all of you know, warfarin is an anticoagulant and protein bound about 98%. Therefore, for a 5 milligram dose, only 0.1 milligram of the drug is free in the body to work. Can you imagine? From 5 milligram, only 0.5 milligram is free and effective. If patient take normal dose of aspirin at same time of warfarin, normally aspirin occupies 50% of binding sites. The aspirin displaces warfarin so that 96% of the warfarin dose is protein bound, rather than the 98 if there is no aspirin. Here, the free concentration will be doubled from 0.1 to 0.2, and this doubled dose of warfarin can produce double effect and may lead to increase the bleeding from the vital organs like cerebral bleeding, GIT bleeding, other important and hazardous bleeding. So we have to understand such important property is competition of several drugs, both of them acting on protein. Dosing interval is how often the drug should be given. The loading dose, which put the plasma concentration in the therapeutic range, is the starting dose. The maintenance dose, routine smaller doses to maintain the steady state, which is the plateau curve. Now we are reaching the volume of distribution, which is a theoretical volume and determines the loading dose. The volume of distribution equal to the dose over the plasma concentration. So from this equation, we can calculate and conclude that the dose equal to volume of distribution multiplied by plasma concentration. And this is the importance calculation. We can conclude the bolus dose from knowing the volume of distribution. So here the dose equal to plasma concentration, which is here represented as our target concentration, multiplied by the volume of distribution. So here there is a question, what's the loading dose required for a drug A? If target concentration is 10 milligram per liter, volume of distribution is 0.75 liter per kilogram, and the patient weight is the 75 kilogram. We are asking about loading dose. The loading dose can be taken by multiplying all these three numbers. This is the volume of distribution multiplied by 75 kilogram. And this is the target concentration. The target concentration multiplied by the volume of distribution. We will take the 565 milligram, and this would probably be rounded to be 560 or even 500 milligram, regarded as a suitable bolus dose for the starting of the effect of this drug, which is here coded as drug A. How the administration of muscle relaxant, for example, rocuronium or fentanyl, affected by volume of distribution in obese and infant in comparison with normal adult person. أحمد باسم.
نعم أستاذ.
أحمد باسم بالنسبة للفنتانيل.
نعم أستاذ.
شلون يختلف يعني affected by volume of distribution إذا قارناه بين الأوبيس والنورمال adult for example؟
يمكن أستاذ إحنا يأثر على يعني الماس الويت بدي الماس ويت مقارنة بالفات الموجود عنده. الإفكت مالته ما راح يكون على يعني على الأول بودي ويت، إنما على الماس بودي ويت.
أوكي. هاجر مزهر.
نعم أستاذ.
الفنتانيل شلون يأثر على in comparison with adult إذا أخذنا الفنتانيل شلون يأثر بالإنفانت؟
دكتور يعني هو البودي ماس اندكس راح تقل يعني تقل بالانفانت، فالدوز راح تقل وتزداد بالاوبيس لانه هو ليبيد سوليبل الفنتانيل.
اوكي اذا احنا to know the effect of a drug we have to know two important points. First, is the drug is water soluble or lipid soluble? Here in these two examples, the rocuronium is water soluble while the fentanyl is lipid soluble. This is first important fact. The second fact regarding the volume of distribution in the obese, the volume of distribution increased in the obese due to an increase in the fat cells. So here it is expected that the volume of distribution for fentanyl increase in a higher way. So we need more fentanyl to get the same effect like that in adult. While the increase in fat in obese will not affect the muscle relaxant in much way because the rocuronium already it is water soluble and will not be affected in higher way in those obese patients. The vice versa when we are talking about the infant, that the volume of distribution increases due to increase in the water. And this increase in the water will lead to an increase in the volume of distribution of muscle relaxant, as the muscle relaxant also water soluble, while not increase in higher way that for fentanyl, because fentanyl is lipid soluble rather than water soluble. And we are talking about the clearance. The clearance is a volume of fluid which is completely cleared of the drug per unit time. The units are liter per hour or liter per hour per kg. Actual clearance is more useful concept in reality than the time half-life or the K elimination, since it takes into account the blood flow rate. That is to say, the clearance take into account the blood flow rate. So the clearance varies with body weight and also varies with degree of protein binding. Maintenance dose of calculation equal to clearance multiplied by steady state plasma concentration. The maintenance dose will be in milligram per hour. So for total daily dose, we'll need multiplying by 24 hours. What's the maintenance dose required for drug A if target average steady state concentration is 10 milligram per liter and the clearance of the drug A is 0.015 liter per kg per hour and patient weight is 75 kilogram. The maintenance dose equal to clearance multiplied by steady state plasma concentration. The clearance here multiplied by 75 kg and here, as you see, the dose by multiplying the clearance with the steady state plasma concentration, and the result will be 11.25. So we'll need 11.25 multiplied by 24 milligram per day equal to 270 milligram. Now we are reaching the third part of pharmacokinetics, which is the metabolism. And metabolism is also called biotransformation, and means the conversion from one chemical form to another. The site of drug biotransformation is the liver, and in the liver there is what is called cytochrome P450, which is known as macrosomal P450. Pathways are used to metabolize most of medications, in the liver, in which enzymatic alteration of the drug structure occur. So, in the liver, there is conversion the original drug that cannot be excreted as it is unless there is a conversion to another form which is suitable to be excreted through the kidney. And the kidney cannot excrete the lipid soluble drugs unless converted to water soluble drugs. And this process occurs in the liver by this group of enzymes. The drugs may induce, activate, or inhibit these enzymes. Means there are several drugs can affect this process, either by activation. Activation means enhance this process, increase this process, and the result of this activation is the decrease in the duration of effect of the drug, or and the example of the drug that activate this process, most of anticonvulsant, anti-epileptic drugs like phenytoin and carbamazepine, while some drugs inhibit these enzymes, and the inhibition of these enzymes will result in an increase in the duration of effect. And the example of a drug that inhibit is the sodium valproate, which is also anti-epileptic, anti-convulsant drug. This process of activation or inhibition, known as one example of drug-drug interactions that we will talk in details in the next presentation, next week, inshallah. The drug biotransformation makes drugs more polar, means water soluble, for efficient elimination. This done by one of two phases, either by phase 1 or phase 2. In phase 1, involving the microsomal P450 enzymes, there will be either oxidation reduction for the drug, or hydroxylation, dealkylation, demethylation, deamination, desulfuration, sulfoxide formation, dehydrogenation. Any of these processes lead to phase 1 reaction. The result of this reaction, conversion of the drug from more lipid soluble to water soluble. Sometimes the liver fail to convert the drug to water soluble by any of these processes. So in this situation, there will be what is called phase 2 reaction. In this reaction, there is conjugation, means the adding of substance or salt to original drug to be conjugated and converted from lipid to water soluble. And this conjugation most commonly catalyzed by glucuronidation, sulfonation, acylation, or methylation. What are the therapeutic consequences of a drug metabolism? After metabolism, what are the therapeutic consequences? There are 6 possible consequences of therapeutic significance. First one, accelerated renal excretion of a drug, and this is expected. Second one, drug inactivation, and this is also expected. While increased therapeutic action, this is unexpected. And we have to talk about activation of a prodrug, also unexpected. Increased toxicity, also unexpected, while the decreased toxicity is expected. So 3 expected, 3 unexpected results from the metabolism. I will repeat them. The consequences of drug metabolism: accelerated renal excretion of the drug, it is expected. Drug inactivation, expected. Decreased toxicity, expected. While these 3, which are decreased toxicity, activation of prodrugs, decreased therapeutic action, are not accepted. Regarding the accelerated renal drug excretion, it is the most important consequence of a drug. The kidney, which is the major organ of drug excretion, is unable to excrete drugs that are highly lipid soluble. So the final result of the metabolism is conversion of lipid to water soluble and will enhance the excretion. And regarding the drug inactivation, the conversion of pharmacologically active compounds to inactive form, like for example procaine, which is local anesthetic, after metabolism converted to para-aminobenzoic acid, which is inactive metabolite, and it is expected. Increased therapeutic action, this is one of unexpected, and we will take an example for this net consequence of metabolism. Conversion of codeine into morphine. The metabolism of codeine leads to producing of morphine. The analgesic activity of morphine is so much greater than that of codeine. That formation of morphine may account for virtually all the pain relief that occurred following codeine administration. So, the effect of codeine actually due to the metabolism of codeine and the producing of morphine, and this metabolism lead to increased therapeutic effect of codeine. Here the codeine converted to morphine by certain enzyme, which is CYP2D6. And if this enzyme failed to generate active metabolite, which is the morphine, there will be no analgesic effect. If this enzyme failed to generate the active metabolite, there will be no analgesic effect. So now this is the rules of 10 regarding the codeine. The codeine represents about 1/10 the potency of morphine. It is lower efficacy than morphine, about 10% converted to morphine by CYP452D6 enzyme, and 10% of patients do not process this enzyme. 10% of patient or population do not process this enzyme. هبة جاسم تسمعيني؟
نعم أستاذ مع
هبة جاسم, 10% of patients do not process this enzyme. What do you expect in this group of patients?
ما أعرف صراحة أستاذ.
Hey, شكرا هبة, شكرا. هند كريم. هند كريم. حسام علي.
نعم أستاذ.
Hussam, what do you expect in this group of patients? 10% do not process this enzyme.
عفوا أستاذ يعني patient G6PD ممكن.
اوكي, شكرا حسام.
شكرا لك أستاذ.
اكو واحد او وحده نازلين باسم ايفون. منو نازل باسم ايفون؟ انا طلبت منكم ان تدخلون هو لمصلحتكم حتى تعرف منو داخل منو ما داخل. بس هذا الايفون ما نعرفه بصراحه.
العفو أستاذ، أنا غيرت الاسمي، ما أعرف إذا دا يطلع بس آيفون، دا أكتب مريم علي.
على كل يلا مريم.
دا يلا أستاذ. أوكي. يعني احتمال يعني نو انرجيسك افكت، غير ما راح يحصلون الانرجيسك افكت مال
يعني
مال المورفين.
ايه ما راح يتحول الى كوداين الى مورفين.
تمام.
راح يصير اكو
انرجيسك افكت.
ايه. فاذا هسه احنا after knowing this fact there will be no surprise if we prescribe codeine for a patient and there will be no analgesic effect. There will be no surprise because 10% of population do not process this enzyme. There is no conversion of codeine to morphine. And this leads to no analgesic effect. Okay, thanks.
Yeah.
Now, activation of a prodrug. This is also an expected consequence of metabolism. A prodrug is a compound that is pharmacologically inactive, as administered and then undergoes conversion to its active form within the body. Like, for example, razipam into desmethyl-diazepam. Razipam is a close relative to diazepam, but it is inactive unless conversion of razipam into desmethyl-diazepam. And also we have two important drugs, enalapril or ramipril, have to be converted to enolopyrrolate and ramiprylate to produce their effects. Now, regarding the increase or decrease the toxicity, the decreased toxicity expected, while increased toxicity isn't expected by converting drugs into inactive form. Metabolism can decrease the toxicity. For example, lidocaine toxic after metabolism, the metabolite intoxic, so the toxicity is decreased, while converting a relatively safe compound into forms that are toxic. For example, conversion of acetaminophen, paracetamol, into a hepatotoxic metabolite. You know, all of you know that the paracetamol toxicity not due to the paracetamol itself, but due to its metabolite. And this product of metabolism and not the acetaminophen that causes injury when acetaminophen is taken in overdose. Now we are talking about first pass metabolism. First pass metabolism is different from the metabolism, which is the third part of the pharmacokinetic. Here we are talking about small topic, which is first pass metabolism, also known as first pass effect or pre-systemic metabolism. Pre-systemic means before reaching the systemic circulation. Is a phenomenon of drug metabolism whereby the concentration of a drug is greatly reduced before it reaches the systemic circulation. And if we look at this graph here, this is the systemic circulation, and here the bioavailability. While before reaching this side, the dose here passes through GIT, and from GIT to GIT wall, and from GIT wall to portal vein, and from portal vein to liver, and from liver to systemic circulation. So the fate of swallowed drugs is to be